Today we are hearing probably the largest portion of our budget, the Medicaid program. So we are going to go ahead and get right into it with the analyst report from Simon Powell. Dr. Powell, kick it away.
Mr. Chairman, before Dr. Powell begins, I just wanted to let you and the committee know I've just been called into finance for a bill hearing, so I'm going to jump off and I'll join you after my hearing.
Sounds good. Hopefully theirs is much more interesting than ours, though I doubt it.
That is not possible. I hate to miss Dr. Powell.
Simon, take it away.
Okay, just want to make sure you can. So can you see the screen?
Yes.
Right. All right. So I'm going to move through the document fairly quickly. Before I start, I'd just like to thank my colleagues and friends at Medicaid for all their assistance in helping me put the document together and for making sure I didn't make too many mistakes. I'm going to start the analysis presentation with Exhibit 2. This kind of follows up the data that we presented in the overview analysis a couple of months ago, showing trends in nursing home spending. You can see from this chart that the number of the elderly bed day utilization at nursing homes and the per capita utilization has dropped dramatically in 2021. And this is really the impact of COVID on this particular population and in this particular program. From a spending standpoint, that results in a pretty significant reduction in spending. We've seen the elderly enrollment drop by almost 5%. We've seen spending in nursing homes from the elderly drop 13.9%. So that we think this is going to result in a pretty significant surplus in the fiscal 21 budget. And we do recommend a budget cut based on that in fiscal 21. I want to talk very quickly about the Health Choice Program. This is the program with the MCOs that most of Medicaid enrollees are served through. I just want to show, as I usually do, the performance of the program against the national HHS measures. The national HHS measures are health plan measures that are used widely in the US, and they encompass a whole variety of different performance measures that plans are judged against. You can see from this chart that in calendar 2019, MCO performance on the whole was actually down compared to calendar 2018. Only a couple of MCOs, Kaiser and MPC, actually improved performance over the prior year. We also kind of put against this the backdrop, which is the kind of like the pink purple line, which is the percent of enrollees in MCOs that are served by the different MCOs. I just want to point this out that 60% of the MCOs, 60% of the enrollees are served in MCOs which have on average performance measures below the program average on national HHS mean scores. AmeriGroup is slightly above that, but in the high performing MCOs, the GIs, MedStar, Kaiser, that only represents about 16% of the total population. So it's kind of an interesting mix in terms of who gets served by which MCO and what their relative performance is. Starting the budget discussion, I'm going to start very quickly going back to fiscal 2020. As you know, we're in a public health emergency at the federal level. As a result of that public health emergency, we get an enhanced federal match of 6.2% on qualifying expenditures. We have to do certain things for that, including we haven't done the annual redeterminations, which is one of the reasons why our enrollment is going up. But we do get this enhanced match. Medicaid initially in fiscal 2020 thought they were going to claim about $95 million of enhanced match. A lot of us thought that was a little low, and they went back and subsequently have done a lot of work, quite heroic work, I might add, to try and figure out exactly how much enhanced match Medicaid should have earned in fiscal 2020. The budget reflects an additional $125 million worth of enhanced match, but the most recent calculations that Medicaid has done indicates that we should actually have another $37 million on top of that, which is one of the recommendations DLS has. For fiscal 2021, the budget recognizes about $488 million worth of enhanced match in the Medicaid budget. We actually think that's a little overstated, but mainly because we think the total spend in Medicaid is going to be much lower than the enhanced match is calculated on. We've also put on this chart in the green column the amount of total enhanced match across all of the different Medicaid budgets. That's Medicaid, behavioral health, Medicaid, as well as DDA. When the budget was put together, the timing was such that the governor did not know that the public health emergency at the national level was going to be extended through calendar 2021. The Biden administration announced that pretty quickly as a way to help states kind of like figure out exactly what funding was going to be available to them. So that means we were able to take additional cuts to the fiscal 22 budget to reflect that 6 months of enhanced match. That's $245 million in this budget and about $317 million across all 3 of the Medicaid budgets. Turning to deficiency appropriations, I'm not going to spend a lot of time on this. I just want to, again, make you aware of the 2 BRFA-related deficiencies, which are the use of the Exchange Reinsurance Fund, as well as the deficit assessment. I know you had the hearing on those yesterday. I will note this $768 million of deficiencies that relates to increased enrollment utilization, primarily enrollment. And you can see in Exhibit 12 that the budget, the fiscal 2021 budget was built on an enrollment of about 1.4 million. Year to date, we're at an average monthly enrollment of 1.5 million. We actually think in DLS that's going to hit about 1.53 million when all's said and done. And we'll talk more about 22 enrollment in a moment. Most of this enrollment has been in the managed care organizations. Not surprisingly, it's pretty much all income-related growth. And one of the things that was brought up in the overview presentation was the fact that the one area of increased spending that we were seeing was managed care. Obviously, increased enrollment means increased capitation rates. And the question was asked whether the medical trends that we saw in other areas would have also been seen in MCOs. We don't have the detail to do that kind of analysis, but we were able to get the data from the HSCRC on inpatient and ED costs for MCOs in calendar 2020. And usually these costs typically account for about 50% of MCO spending. And what you can see quite clearly is that in March, April, when hospitals closed down elective surgeries, when people were definitely more concerned about going to hospitals, there was a significant drop in spending and in admissions. That picked up after that. Spending particularly increased because the HSCRC, as you know, through their global budgets, allowed hospitals to recoup some of the revenue losses that they'd seen in March and April. And you can see if you on the next slide, I have to maneuver, which looks at admissions and admission costs. The costs per admission have grown pretty much since March. Now, I will point out that when you look at actual admissions, both in terms of the numbers and also the relative admissions by program participants, inpatient and ED costs have been coming down pretty significantly since 2018, and 2020 looks to be no exception. I will note that as those costs come down, the line at the top is actually the capitated rates for MCOs. And on a per capita basis, those rates have held pretty steady. So I think it's pretty fair to say that it's likely that there will be some savings from the MCO program in calendar 2020. We have in place the normal medical loss ratio, MLR ratio captures below 85%. And the department also put in place for 2020 and 2021 risk corridor arrangements. Those arrangements are such that if you have expenses that are low relative to actual revenues, the department will share in those. If costs are high relative to revenues, then the state will actually kind of share in some of those higher costs. The specifics vary from 20 to 21. But those arrangements will, I think, bear fruit in 2020 in terms of some savings. We're not making a recommendation on trying to estimate what those are. That will be done through the risk corridor reconciliation process. But we do think that will occur. I'd note that the preliminary estimates for 2020 indicate that at least 6 of the 9 MCOs have MLRs below 85%, which is the target, and that total profits in the program could be as high as $300 million. turn to the 2022 budget, we're showing budget change here of about $440 million, total spending $11.6 billion. The big story here, though, is in that general fund, special fund, federal fund line, specifically general funds going up by 36.4% in fiscal 22 compared to 2021. That's to backfill for about $614 million of one-time federal funding in 2021, as well as the backfilling for special funds. The special funds is a technical adjustment that reflects the fact that the funding stream into the rate stabilization fund is no longer going to Medicaid. It's now going directly to the general fund based on the BRFA action you took last year. In terms of what's driving costs, it's still enrollment. This shows month-over-month change in the program since January 2020, and you can really see the impact of COVID enrollment beginning in March 20. That's both a combination of the ending of the annual redeterminations plus people coming into the program because of economic dislocation. Trend line is going up, and we expect that trend line to continue to go up throughout the whole of calendar 2021. At this point, we'd expect redeterminations to begin at the end of calendar 2021. That may change depending on if the public health emergency is extended. And we are expecting a fairly healthy decline in the population in the second half of fiscal 22. Nevertheless, that means we still think on an average monthly basis, we'll have about 1.6 million enrollees in fiscal 22. That's a little higher than the allowance, but again, that's a timing issue because the governor didn't know about the public health emergency extension and the impact that would have on enrollment. Other big change to point out in the program is in provider rates. It's actually, there's not much change, but I do want to point out here that one of the things in the original allowance was there was a placeholder of about $8 million for physician evaluation and management rates. These are the diagnostic codes that most physicians use when they see patients. And the program has been trying to keep the physician E&M rates at about 93% of Medicare in recent years. So $8 million as it came in was a bit of a plug. As it turns out, unfortunately, or fortunately for the physicians, Medicare is actually jacking up their physician rates pretty significantly in calendar 21. So to actually keep the Medicaid rates at that 93% level, we need an extra $84 million over and above the $8 million. And of course, you probably saw that in supplemental budget number 2, that $84 million was added. So the physician rates will actually be maintained at that 93% level in fiscal 2022. That concludes pretty much our review of the 2022 allowance. We do think, again, that because of trends in nursing home as well as trends in fee-for-service pharmacy, there will be a significant surplus in fiscal 22, and we are going to recommend a fairly substantial cut on that basis. There are 3 issues in the analysis that I just want to turn to. The first relates to going back to health choice program quality. I just want to note that the program, we do serve now close to almost a quarter, right now in the pandemic, almost a quarter of our state's population in the health choice program. And the program does spend a lot of time and emphasis on trying to improve quality. And one of their big goals is to look at that big HEDIS data set that the program uses, and they like to have at least 70% of those chosen measures above the national HEDIS mean. So they want to see MCOs with 70% or more of their measures above the national HEDIS mean. And you can see in the last 5 years where red indicates MCOs that fall below that mark and green is above, there has been a kind of a trend to more MCOs being below that 70% mark. In some cases, you have to be a little bit circumspect about that because when you have a new MCO, like University of Maryland Health Partners was in the early years and now Aetna in 1819, those programs often struggle with their HEDIS measures. But it is a little disconcerting that some of the more established MCOs, the ones that have been around for decades, Priority, MPC, and United, are also falling into this area where more and more of their HEDIS measures are below the national HEDIS mean. Just we took a look at trying to graph the performance against these HEDIS targets with profits, just to see if there was any trend that was discernible. We just took 2 years, calendar 2018 and 19, and we graphed the performance on HEDIS, which are the circles, against their profits, which are the squares. And it's the blue ones I want to focus on, which is the most recent performance. And what this chart does, you really want to be in the top right-hand quadrant, right? You want to have good performance, but you also want to have profit. And for the most part, you can see the small MCOs, JAI, MedStar, Kaiser, the relatively small MCOs, which have good performance. But they also struggle to make profit. Only JAI in the last 2 years has actually made a profit amongst those MCOs. AmeriGroup is kind of interesting because they do meet the 70% target that Medicaid sets, and they also make profit. When you go to the left, the reverse is true a lot of times. MCOs not meeting the targets, obviously, but also not necessarily making profits. Aetna is a bit of an outlier on this chart. In calendar 2019, they do look like they'll make a profit, but their performance is very poor. But that's because they are a new MCO, and a lot of those HEDIS measures are new for them in terms of measurement. So you kind of have to take that with a pinch of salt. The major quality program that the department runs, as you know, is the Value-Based Purchasing program. It's a program which sets certain targets for the MCOs in certain measures, and they can earn incentives if they meet those measures. They are penalized, disincentivized if they don't meet those measures, and up to 1% of their rates are at stake. The disincentives are intended to fund the incentives. This is a program we've talked a lot about in recent years, and we're going to talk about it again because it's creating a little bit of controversy this year, as it has done in the last couple of years. Once again, in calendar 2019, the top performers, which are the MCOs to the right, University of Maryland Health Partners, JAI, and Kaiser. You can see there are a lot more greens, which are incentives, good performance, outweighing their disincentives or penalties. To the left, you have a lot of the bigger MCOs who don't perform well in VBP, and we collect a lot of penalties from them. And because they're big MCOs and up to 1% of their rates are at stake, those collections are pretty large. In calendar 2019, the state's collecting almost $35 million in disincentives. Those disincentives pay for the incentives. And in the first round of incentives, which are based on the actual performance on the measures, about $4.2 million is paid out to University of Maryland Health Partners, JAI, and Kaiser. Then there's the secondary distribution, which basically allocates the funding based on the top 4 performance measures, top four performing MCOs, as well as enrollment. And there you see AmeriGroup getting $12 million in total payouts, even though the number of disincentives they have far outweighs their incentives. That's always been a concern to DLS, and it was one of the reasons last year we proposed in the BRFA, and you accepted measures to try and change that secondary distribution, but that wouldn't impact until calendar 2021. The department's concern is, I think it's always been that as well, but they're also specifically concerned about the extent of the incentives that are being collected through the disincentive pool. And certainly when you look at the amount of money that Kaiser and JAI and University of Maryland Health Partners are getting in that secondary distribution, it's pretty significant. In all, Kaiser's payout under this program totals almost 3% of their net premiums, which is really quite substantial. For JAI, it's about 2.4%. So as a result, the department has decided to move to a more incentive-based program, or incentive-only based program, and they're looking to shape that. Frankly, it's a concern to a lot of the MCOs, especially the smaller MCOs like JAI and Kaiser, who do well under the program. But it's their attempt to try and focus on quality, but get away from disincentives. And obviously that's a major issue, and we've asked them to comment on that this afternoon. Second issue I just want to talk about very quickly concerns the rebalancing of long-term care services. This was an issue that has been quite big in the policy committees the last couple of years. basically as attempts to expand waiver services through Medicare, through Medicaid, have been debated and discussed, and often quite heatedly discussed on the floor in terms of what the cost of expansion is. You all asked the Medicaid and Hilltop, UMBC, to do a study last year on what it actually cost to expand waiver slots. And the report we got, which was a draft report, although my understanding is it's not going to change that much, was really quite fulsome and detailed and attempting to answer that question. I would just note that we have been trying to rebalance in recent years. We've been trying to move away from institutional long-term care, which is nursing homes, and using a variety of home and community-based services through federal programs. And we expect that to continue. In terms of waiver utilization, I would note that the biggest program that we have, which is the community options waiver, has a waiting list of about 20,000 people. What's interesting about that is, as was part of the study, is about half of those folks are actually Medicaid eligible. They're either part duals, which partly dual with Medicare, full duals, or else just Medicaid eligible. And some of them already get some kind of Medicaid benefit, including home and community-based services. You might wonder why you'd want to still be on the registry or the waiting list for the waiver if you already get home and community-based services. And the answer to that is the array of home and community-based services you can get under the waiver is far more significant than you can get under Medicaid. So the Hilltop study did the analysis that was asked of, and they basically, the easy question was how much do people spend on the waiver versus those who are on the registry? And what they did was they compared essentially the cost of being a slot cost in Medicaid versus what people who are Medicaid eligible spend who are also on the registry. And the difference is about $40,000. And you can see clearly it's driven by the extent of the home and community-based services that people on the waiver get, which is what you'd expect. What they also did then was kind of like discount this number and basically say, well, if we look at the cost of, because you could quite easily say, well, it would cost $40,000 per slot to add a slot. But then they made a couple of adjustments. And they basically said, well, waiver slots aren't always fully occupied, so we're going to discount for that. We're also going to make an adjustment for the fact that, the people on the waiver are probably sicker than we think. And so their Medicaid costs are probably higher. And when you do that, you get to a net difference of about $20,000 for a single slot. So that's the kind of cost, about 10,000 general funds. I think that's much lower than the departments used in the past when they view those bills, but there's still a cost. Now, I will say that some of the benefits to using waiver services are not quantifiable, right? They're about trying to keep people in their homes, trying to keep people in community and out of nursing homes, and that we can't quantify. The other thing that's interesting is, and the department acknowledged that, is that when you look especially at the dually eligible, the benefits of putting people in waiver slots and reducing their Medicaid expenditure, their hospital costs, actually, those benefits accrue to Medicare, not to Medicaid. So what would be interesting is to try and work with Medicare to see if there's a way of sharing those savings. And then that shared savings could actually fund some of the costs of the waiver slot. And other states have attempted to do that. Washington State has done that through its Health Home program, whereby Medicare calculates how much the program is saving Medicare in Medicare costs. And they shared that with the state. And the department's committed to going ahead to do that work. And we've just asked them to kind of follow up in committee narrative. The last issue that I'm going to present is the Senior Prescription Drug Assistance Program. This is the program that, specifically, I'm going to address the BRFA issue. This is the same issue that you faced last year. Essentially, the BRFA proposes that the Senior Prescription Drug Program, $14 million, be a floor rather than a cap. And that offsets with the CHRC, the Community Health Resource Commission, $8 million, their floor becoming a ceiling. Last year, when we did the analysis of this and forecast projected expenditures in the prescription drug program, we calculated that there was enough fund balance in the drug assistance program to actually not make that change, and we recommended that you did not need to do it. And in fact, that's what you did. You rejected the BRFA proposal. Well, it's back again this year, and based on our analysis, we think that you may have to make some change this year. And the reason for that is that the prescription drug program actually increased the premium subsidy, the maximum premium subsidy, from $40 to $50 effective January 2021. And that's going to drive up costs. So our proposal on this is that you actually have increase the cap for the senior prescription drug program you basically fund the prescription drug program at $11.5 million, which is $2.5 million less than the governor proposes. So that gives the CHRC an additional $2.5 million of spending. But we do think you have to confront the fact that the funding stream to support these two programs, the senior prescription program and the CHRC, which is the Care First premium tax exemption, is not adequate to support these programs going forward. So whether you do it this year or whether you have to, you try and punt again till next year, this is an issue I think you'll have to face up to at some point. So that takes us to the recommended actions. I'm going to go through these very quickly. The first action is to limit the program funding and provide reimbursements for that purpose. This is annual budget bill language. And we're also recommending that you add that to the Children's Health Program in fiscal 2022. And the reason for that is because of the uncertainty about how long the enhanced match will go into effect for. Recommendation number 3 is to cut funding by $750,000 based on an action you actually took in last year's BRFA, which was to allow the transfer from the Board of Pharmacy to fund Medicaid. Recommendation number 4, this is a recommendation which is based on the availability of funds from the Cigarette Restitution Fund, and it relates to the funding of Boost, which will be discussed in different subcommittees. But essentially, if those subcommittees, as DLS is right now recommending, cuts the funding for Boost, then that means a general fund cut in Medicaid because you'll have more special funds to support it. Recommendation number 5 is just to reduce general funds for the non-emergency transportation program, and that's just using the most recent actual federal fund attainment level. So recommendation number 6 is the $77 million cut based on service utilization trends in fiscal 22. 7 is the cut based on the enhanced match. 8 is simply technical. It ties back to that Boost cut recommendation. 9 is the recommendation about narrative to get more information on the risk corridor settlements, which will be hopefully resolved immediately after session. Recommendation number 10 is the language recommendation about looking to see if the department can figure out a way to get Medicare to share savings on any savings they do through waiver expansion. Recommendation number 11 is a technical recommendation related to the amount of funding that's contingent in the senior prescription drug program based on our recommendation to change those funding levels in the BRFA. Recommendation number 12 is the deficiency appropriation of $75 million cut, and 13 is that $37 million cut based on additional unrecognized fiscal 2020 enhanced federal match. And the one BRFA recommendation, as I said, it relates to the senior prescription drug assistance program, setting that minimum appropriation at $11.5 million, not $14 million. And that concludes my presentation. Mr. Chairman, happy to answer any questions.
Thank you, Simon. Let's start with questions. Senator Eckhart and then Delegate Henson.
Thank you very much. And thank you, Dr. Powell, for your wonderful explanation of a very complicated budget. I have 2 questions. First one on the long-term care waiver for dual eligibles. If we were able to negotiate some savings in that, could that be then used for the prescription drug benefit, senior benefit?
I mean, I think our thought was that since we do believe there is a net cost to Medicaid of expanding slots, that any shared savings arrangement you can do with Medicare should go to offset the cost of those slots.
Got it. Okay. And then my other observation, we've been doing a lot with diversity and disparity. And when I looked at those scatter maps, I think they're called scatter charts regarding our MCOs and performance, it was interesting to me that when I look at what's on the Eastern Shore, in our lower income areas, we don't have a lot of Jais and Kaisers on the shore. So I didn't know if that was a factor in the performance or outcomes for many of the MCOs, and or if complicated care, folks a lot of times I know in some of our areas on the shore have more complex care than others.
I mean, I think that's part of it. I mean, clearly for the Kaisers and Jais, which are more clinic-based, it is, I'm not going to say it's easy, but it helps them being clinic-based to meet some of these performance measures. I think priority, and again, this is generalization, priority, for example, which is the most prevalent MCO on the shore,
Right.
used to be a higher performing MCO. It's slipped in recent years, and that may have something to do with it. Your question about racial equity is interesting because one of the disappointing things about the Medicaid program, and it's not their fault necessarily, is that we don't have good data on performance in terms of by race. And that's because in the exchange program, the connection that does the enrollment, race identification is optional. And so about 30, I think last time I looked, it was over 30% of folks don't actually identify. And so that's a huge percentage, and it makes it kind of difficult to get at the issue of how our MCO is performing in terms of cultural competency and reaching out appropriately. I don't know if there's a way around that. I know the department's very interested in trying to do something in that regard, but that's a big stumbling block, is knowing that about a third of the enrollees, you don't know what their race is.
This would be interesting because, Maryland has been a waiver state with regard to, for years, because we didn't want to have winners and losers in hospitals. So we didn't want to have public hospitals and private hospitals. And it just occurred to me, do we need to, even though the MCOs reach a variety of people, are there still disparities there that we're not recognizing because we don't have the information? So
no, I agree. We know obviously they're all low income because they meet the income criteria, but we don't know enough about the other aspects, which is which I think would be very useful.
Thank you very much. Thank you.
Thank you. Delegate Henson.
Thank you, Mr. Chairman. And thank you, Dr. Powell, for the very detailed and excellent analysis. I have another question about the low income population. On Exhibit 9, there's you do the analysis on some cuts that were made by the BPW, and one of them is the reduction to Washington Children's Hospital there. And it looks like, I'm trying to make sure I understand the impact of that. Was that rate cut to Children's Hospital, is that a permanent reduction, or was that just something that's temporary? I thought that we had increased the rate to our hospitals. Can you help me understand the scope of that? Sure.
So the Children's does not fall under the rate setting, because obviously it's in DC. It's not part of the Maryland rate setting system. So we have a special provision in regulation for setting their rates. The BPW cut those rates on the fee-for-service side, and the 22 budget includes funding for a rate increase, but it's off the lower base. So my understanding, I actually asked Medicaid this specifically, and they can confirm it. Essentially, the rate is pretty much flat funded between fiscal 21 and 22, but they've basically gone back up in 22, but they're not restoring the fiscal 21 cut.
So I want to understand that. Does that put them on par with the hospitals in Maryland for the services they're providing for Maryland residents there at Children's, or where does that align them with the Maryland hospitals?
I mean, I don't know. I mean, maybe Medicaid could answer that one when they get up, because I'm not sure exactly how it aligns, because our rate setting system is so different. And so I honestly can't answer that question in terms of how they line up relative to Maryland hospitals.
Okay, thank you. I'll reserve for the Medicaid. Thank you. I appreciate it.
Thank you.
Thank you. Are there any other questions for the analyst? All right, seeing none, let's go to the department. The Acting Secretary, Dennis Schrader, Acting Medicaid Director, Tricia Roddy, Chief Financial Officer, Jordan Butler.
Thank you, Mr. Chairman. First, let me thank Dr. Powell for his analysis. As always, it was very in-depth and very excellent. We have submitted responses to the questions, and in addition to the Assistant Medicaid Director, we actually have promoted Trish Roddy to Assistant Medicaid Director recently, as well as serving as the Acting Medicaid Director, and Jordan Butler, the CFO. But we also have the Medicaid Finance team, Jennifer McIlvain and Angie Huffman here, who could take questions, as well as Fred Doggett from the IG. And the IG provides a very valuable service to the department, particularly within the area of Medicaid. The last thing I'll say is that one of the things we're very pleased about with Medicaid during this pandemic is, as a major health plan in the state, we've taken the lead on a couple of issues. For example, last summer, when we were ramping up the testing effort, and there was a lot of back and forth about who's going to pay for testing, Medicaid said we would pay for it because it was the right thing to do for our most vulnerable citizens. And I think the other health plans have followed that lead. And then the other thing we've done recently is made sure early on, when the vaccine was available, to give doses to the federally qualified health centers. They take care of about 300,000 of our primary care patients around the state, 5% of the population, and they are largely Medicaid recipients. So very proud of that. So I'll stop there, Mr. Chairman, and we'll take questions.
Okay. Delegate Henson, I had a feeling that was coming.
Thank you, Mr. Chairman. Thank you, Secretary Schrader. I appreciate the opportunity to ask the question. I want to repose my question about what I saw on Exhibit 9 and trying to understand what's happening there at Children's Hospital, just extending the conversation on our low-income population. I know that that population tends to over-rely for a number of reasons on hospital visits. Just looking at a number of health challenges, that population can tend to be more acute when it needs care. A number of different health challenges where the hospital visits are critical to keeping that community safe and healthy. And when I saw that it's indicating that there was a rate cut for them, I'm trying to understand if that rate cut is permanent or if that's temporary, and then what's happening there in the future, because I thought we had increased our rate for hospitals. So just trying to understand the scope there.
Thank you, Madam Delegate. Let me start by answering the question generally, and then I'm going to ask Trish Roddy to handle the specifics. Because of our rate setting system in Maryland and with the global budgets, we often find that some of the DC hospitals have costs that are much higher than our system, and that puts Medicaid in a difficult place. We try as much as we can to sustain their rates, but oftentimes we have to make adjustments for the rates that are not in line with our rate setting system. So, Tricia, if you could maybe touch on the issue of its permanence, that I'd appreciate it.
Absolutely. So, yeah, it is a cut that's being carried over into the next fiscal year. And just to kind of emphasize again that what Secretary Schrader said, as well as Simon, they're two different processes in which rates are set for DC hospitals as well as for the Maryland hospitals under the Health Services Cost Review Commission. What we look at when we look at the DC hospitals is we look at their charge masters. We're not going in and challenging the charges that they've put together. Whereas when the Health Services Cost Review Commission looks at a hospitals and regulates how much they can charge, they look at those costs and those structures very closely and make sure that they indeed warrant a rate justification. So they are two very different processes in which we establish rates. We can share with you just in general what the per case charge would look like. But again, it is something that is being sustained forward.
If I may be permitted an additional follow-up, Mr. Chair?
Mm-hmm. Yes, please.
Thank you. If I'm understanding the secretary correctly, it sounds like the cost is greater for our hospital in DC that are servicing our Maryland children. And I don't understand how that translates to us paying them a lower rate. Can someone help me understand that?
So again, I'm not quite sure we said that we're paying them a lower rate. So the HSCRC did give the hospitals a rate increase last July. How that compares to the per case rate at DC Children's, we would have to look at the specifics of that. What we get every year from the DC hospitals is their charge master list, and then we set rates based on that. Again, we are not looking at the appropriateness of their charges within that charge master list. We're not, we're not doing the level of scrutiny that the Health Services Cost Review takes a look at the Maryland hospitals. So it's two different processes. We're happy to kind of give you, an apples to apples comparison in terms of what a case would look like and how much we would reimburse under both those structures. Again, probably a comparable hospital would be like Hopkins or University of Maryland. It wouldn't be a community-based provider, but we could take a look at that for you. Also, just to note that the cut is only on the fee-for-service population. It doesn't include the MCOs.
I appreciate that explanation. So that I'm clear, it is parity for the fee-for-service between what's happening at Children's and what's happening at Hopkins. Is that the test? Is that your response?
I didn't say it was in parity. I just said that there are two different processes in which we establish those rates. Again, the HSCRC did give a rate increase for the Maryland hospitals, but we could provide the specifics for you.
Thank you. I just want to underscore that our hospitals that are servicing our children are dealing with the sickest populations. And it's often, especially when we're speaking about our Medicaid population, it's the lowest income families that are really relying on those hospital services. Other families that maybe are able to access more primary care services are able to maintain health in different ways, but relying on the emergency room visits to really take care of the most acute care needs, it's really critical. So when I saw that we did a rate cut there, I just wanted to make sure that we still were encouraging them to accept patients to participate and that it was still attractive options for them to be able to find care there. So thank you for answering the question. I appreciate it.
Thank you, Delegate Henson. I'd actually like to do a follow-up as well on that issue. Ms. Roddy, can you remind me, I am assuming I don't actually know the answer to this, so please tell me. In Maryland, the hospitals cannot turn away anyone based on our all-payer system. Does that also apply to DC hospitals?
All hospitals that receive federal monies have to comply with EMTALA rules. So you can't turn away a patient. So that applies to both DC and Maryland, as long as you're getting federal dollars.
So those of us in the capital region, Montgomery and Prince George's County, who send our children on Medicaid to Children's Hospital on a regular basis, if Children's is not getting enough of a reimbursement rate from Medicaid to be able to see those kids, what kind of an effect could that potentially have on not just the patients from Montgomery and Prince George's, but the hospitals within Montgomery and Prince George's that might have to bear the brunt of this equity.
Yes, I understand your concern. And I guess in my response, I would say, one, we haven't actually seen what their costs are in terms of comparison to our chart, what we pay. Secondly, I will just emphasize that, again, this is for the fee-for-service population. The majority of our children, again, are served under our MCOs, and they negotiate separately. They're not required to follow our fee-for-service rates for children. So the majority of the children, again, are served under Health Choice.
Okay. I believe Children's is signed up to testify on this. I would strongly recommend you stick around and hear what they have to say as well.
Yeah, absolutely.
Right. I'll have some more questions on different topics later, but let's go to Senator Eckhart and then Delegate Valentino Smith.
Thank you very much. Thank you, Mr. Secretary, and thank you, Trish and team, for all the good work you've done through COVID. Can't say enough about that. I did have one concern, and I just came to me, but our medical adult daycare centers have been not operating. And as you know, Trish and others, I've been concerned about the viability of them in rural areas. They're really important. The way the payment structure is, it's really difficult for them to continue to move forward. But I'm concerned, have we factored them into the whole reopening system so that we can provide opportunities for our seniors in safe environments? That's one question. And then I had another one, but.
Madam Senator, I'll take that. And again, the general question, and if Trish wants to add anything, we are actively looking at, how that might unfold, especially since we're now we've vaccinated 40% of the adult population 65 and older. So we are evaluating what would be the correct timing medically to bring those centers, both adult medical day as well as senior centers around the state. We're not there yet because we want to be very careful, but that there are active analysis and discussions going on that very issue as we speak.
Yeah, and I would just ask, it's been hard to get information on how the referral system goes for folks who remain in the community and utilize medical adult daycare. We used to have a real clear geriatric screening assessment that was done by professionals. And I would just suggest, if we're looking at this as it reopens, why don't we go ahead and take the time to look at a clean system on how we do determine who gets what elements of care. That would be helpful. Thank you. And then my other question has to do about the value-based payments and how we are going to be looking at incentives only and changing the way we move forward, and will that impact the quality of care, or just a little bit? I know you've given some description in your response, but can you explain it a little bit to me? Thank you.
Yeah, let me again give the big picture, and Trish can give the details. The bottom line is what we have found over the last several years, and I think Mr. Powell explained, Dr. Powell explained this very well. We're seeing a reward on the second round, because what we do is we have a first round of payout, and that is based on metrics. And then the second round of payout is shared among a pool of a certain number of the MCOs. And when we started looking at that very carefully over the last 2 or 3 years, again, at the prompting of Dr. Powell, and it just didn't make any sense, and we started realizing we weren't really paying for performance. So what we want to do, and we believe it will improve quality, is pay for performance. And Tricia, do you want to add anything to that?
Yeah, I'm happy to. So, I think generally, again, Simon and Dennis gave a great overview of why we're doing this. And we really did say to the MCOs last fall that quality was going to be a priority of the departments. We were concerned that the number of MCOs across multiple years who were not achieving the standard of having 70% of the HEDIS measures at the national average. At the same time, we were very concerned about how the value-based purchasing program and how it was structured was basically rewarding MCOs that didn't necessarily see an increase in their enrollment, as well as an increase in quality improvements. So the way that the program is structured is we pay all the money out at the end of the year. Simon did make some changes, but those don't go into effect until next year, or calendar year 21. But you'll see in our response that some of the smaller MCOs have not grown, but they've been basically, their enrollment has been stable, but their incentive payments have increased almost 300%. And so our goal under value-based purchasing is to move the performance of all of our MCOs. We also noted that CMS changed its rules a few years ago, where they require us to basically build disincentives into the actuarially sound rates. So that means that we have to fund the disincentives in order to collect them. And so this has caused a bit of angst with our MCOs because it's not very transparent in whether or not that the rates have been set in a way that supports the collection of disincentives. So if we move to an incentive-based only program, that incentive pool is outside of the actuarially sound rates. It's an incentive. It will be clear what the MCOs will be able to achieve and receive each year. And we've been working through a process with the MCOs. We're looking at the measures. We're also looking at the incentive threshold. So we've reviewed the measures. Next week, we will be working with them to look at how we might restructure the incentive thresholds. And the other issue that we put on the table is whether or not there should be a baseline in which you can actually participate in the incentive program. So going back and tying it to our 70% HEDIS measures, whether or not that should be a baseline in which they can even participate and receive incentives.
Thank you. Thank you, Madam Chair and Mr. Chair. Thank you.
Thank you. Vice Chair Valentino Smith.
Thank you, Mr. Chair. So I think I'm assuming that the secretary was done with the testimony, right? And we're just asking questions now. Okay.
Would you?
I just wanted to do a follow-up from the good chair asking about Children's Hospital and the good delegate from Anne Arundel County. When the cut was done at the Board of Public Works, as far as you know, Ms. Roddy, was that just an arbitrary cut at the time? I mean, was that discussed with you, or was it based on anything, or was it appears that quickly in the heat of the moment to get savings and all, it might have just been an arbitrary cut and then now not restored. Do you know if it was based on anything? Did they talk to you, the Board of Public Works, anybody? They just throw a dart, or?
No, it's a process where we work with DVM to come up with our list of cuts before it goes in front of the Board of Public Works. So it is an active process that involves both the department and DVM as well as the governor's staff. So I wouldn't say it was a dart in the board. We were looking at that point in time, some really hard fiscal outlooks in terms of the state revenue, and we were making some hard choices at that time.
Thank you. I recognize it was hard. I think the good delegate from Anne Arundel County was pushing the fact that we don't want to risk the historic provider, and that if it was a hard decision then, why it's not been restored so that their baseline is calculated correctly. Obviously, you've heard the concern from the committee. I wanted also to follow up a little bit more on the good delegate from the Eastern Shore. Maybe nurses think alike. I'm very concerned about aspects of the value-based purchasing program. Also, one, I find it unusual that we have contracts with MCOs to do a job, and then we have to actually give them something to try to do a good job versus the job they're supposed to do. So I've always struggled in that area. But now I'm struggling even more with the redesign of the program and the fact that there will not be disincentives. And I'm concerned about what the market forces are then to not just make a decision based on the volumes that they have and the profits they can make to not invest. And if there's no disincentive, it seems like it will marginalize or increase the ability to marginalize care decisions. And it was very concerning when Dr. Powell, you talked about wanting to measure MCOs, it sounded like, on whether they're growing. But what Dr. Powell told us was in 60% of the program, 60% of the population are in programs that are below average. Those are the bigger programs. And it doesn't sound like bigger is better. So we can have an MCO, maybe have like a 10% or whatever mammography success rate, and then 80%, and they get paid the same. What is besides saying we want you to do a good job and you'll get paid without a disincentive, how is this going to work?
So we have the ability, Simon touched upon it a little bit. So we have attached to the contracts, we have a health choice performance monitoring plan. And within that performance monitoring plan, we do sanction the MCOs. So if their performance over a consistent period of time falls below expectations, we can take financial sanctions as well as freeze enrollment or other measures. And so we have highlighted to the MCOs that more emphasis would be put on the health choice performance monitoring plan. So as we move to the incentive-based program, we will at the same time put more emphasis on the performance monitoring plan where we can take sanctions, and we do. And again, that's attached to the contract. And we'll be happy to share that with you. And the only other comment I'll make, I really want to emphasize that CMS requires us to fund disincentives. So in order to collect disincentives, we've had to put it into.
They won't leave till 6 p.m.
Sorry, 1 second. Can everybody who's not speaking go on mute? Thank you very much.
So, my point is that the point I'm trying to stress there is that in order to take $5 million from the MCOs, you've had to include that $5 million into the rates in order to collect it. So moving to an incentive-based program, again, we will clearly be able to tell the MCOs what needs to go to medical care. And then on top of that, we'll very clearly allocate what will be available for incentives. And we will partner with all of you in terms of whether or not we've set the right thresholds and the pool of money in terms of which we can reward and move performance amongst our MCOs. But
so thank you. I just would be interested in, and we'll get back to us, or we'll follow discussions on whether you have ever issued sanctions against any of the MCOs for their performance based on their contracts. And if those performance measures line up with the value-based purchasing measures, or there's some alternative now in third. We have HEDIS, and we have value-based, and then we have some kind of contract provisions. And it sounds like they might be not all in alignment for those purposes. The second question I had comes with, we get tons of testimony, whether we have time to read it or not is always suspect, but I had time last night. So it looks like Kaiser and some of the others that are coming up have concerns about a pilot that was proposed to do some behavioral mental health modeling. And we're kind of being told there was a work group, systems of care work group that usually looks at all proposals for pilots in the Medicaid program. Have you guys suggested any pilots for carving out or doing behavioral mental health outside of the MCOs? Or are you part of that system of care work group?
Yeah, let me jump in. We spent 2019 on developing a system of care process, and we spent the whole year, and we were reporting back to the legislature. We had to put that process on the back burner through this COVID crisis, and we're anxious to get that back up and running at some point. I can't predict when. I'm hoping it'll be before the end of this year. But there's no intent right now to do anything different with the MCOs. But we do have a focus in those discussions, and it's really unfortunate because we have tremendous momentum during 2019 to address some of these things, and we did have to put it on the back burner.
So would it be fair to say you would be suggesting that any pilot really not take place until it had the chance to go through that SOC process?
On Monday, December 9th.
I'm sorry, Madam Delegate, I didn't hear your question.
So is it fair to say?
1 second, Senator Rosenberg, could you please?
777-1301.
It happens to all of us still. So I guess, Mr. Secretary, the question would be if pilots were being proposed and they hadn't really had the chance to run through your SOC process where there was a lot of stakeholders and a lot of input, it would be premature?
Unless Tricia knows of another pilot, I'm not aware of one, particularly about this issue of the relationship between the MCOs and behavioral health. If it's another, I mean, we have other pilots, like we've got the MOM grant for opioids, and those are being done in due course, and that's a grant. But we were really focused in the system of care on the overall public behavioral health system and how it related to the managed care program. And as I said, that's on the back burner until we get through this crisis.
Thank you, Mr. Chair. I think this is our last chance, or my last chance, to ask the Secretary and his team any questions. And so I just want to thank you for all your work during the crisis.
Don't worry, we got DDA tomorrow.
Oh, I'll get another chance. Okay.
I want to follow up very quickly on value-based purchasing. Just very quickly. This is less of a question and more of just sort of a comment, and just to take back with you while you're evaluating. For the MCOs that are doing well and have been getting in the past that second tier disbursement of money, they use that money. And in some cases, they use that money to fund services and programs for their clients that are otherwise not coverable under existing Medicaid rules. By not doing that second disbursement, and in some cases, it's millions of dollars to some MCOs. Actually, in all cases, I believe it's multiple millions of dollars to MCOs. The reality is that they may have to cut those services that are otherwise not billable. So while you're looking at this reevaluation process of how we incentivize MCOs to do better, we also have to recognize that the money that they get needs to also be is being used in a variety of ways, and that simply cutting the second tier disbursement can potentially hurt Medicaid patients. And so I'm not really looking for an answer right now necessarily. And I realize that everything is being done. It's a capitated system, and they get a certain amount. It's not like it's fee for service. I get that, right? But it's the additional money is being used in many cases for additional supplemental services. And that needs to be taken into consideration while you're rethinking this program.
Yep, I would just say I would agree absolutely with that comment. All of our MCOs do provide supplemental benefits, not just the ones that are doing well under value-based purchasing. And again, I'll just highlight in the response that we have, you know, we're just talking about how the structure of the program has really kind of changed over the last few years, where it was around, you know, 1.7 million for one of our small MCOs, and now that amount has now grown to be over close to $7 million. And most of that is driven through the second round payout. And so we're just, again, recognizing that that's probably not what we want to be achieving or under the program, and right now is absolutely the right time to relook at it. There's been tremendous amount of growth in the program under COVID. We're serving much more people. We don't know how many of those will fall off and at what rate they'll fall off when we get back to normal circumstances. But for right now, we're serving almost 1.3 million members under Health Choice. And so we need to look at all of the MCOs, not just the ones that are serving 30,000 or fewer enrollees. We need to be looking at the larger programs and MCOs as well.
Thank you. Any other questions for the department? Seeing none, let's move on to our witness panels. We will have 3 panels of testimony today, 2 favorable, 1 unfavorable. I have tried to group them as best as I can. So we'll start with the first favorable panel. We will start with Allison Taylor for Kaiser Permanente, Jai Sunarine from Jai Medical Systems MCO, Brian Frazee from the Maryland Hospital Association. Oh, I'm sorry, never mind. Just those 2, go ahead.
Great. Good afternoon, Mr. Chair and members of the committee. My name is Allison Taylor, and I'm here today on behalf of Kaiser Permanente. We serve about 97,000 members in the Health Choice program, and I want to talk to you about 2 things. One is we are interested in something related to behavioral health services. We have kind of a unique situation here in that we provide coverage to Medicare, commercial, and Medicaid patients. And Kaiser members usually get their services through a Kaiser physician. And so that would include their somatic, specialty care, behavioral health care, all of that. Unique situation in the way that Medicaid is financed in the state, in that our commercial members are able to get their behavioral health services just in the same building as they're getting their other services, but that's not true for our Medicaid members. They tend to have to be referred out. Because of the pandemic, we're experiencing some churn in our membership, where we have some members who have lost their commercial coverage, but they may end up on Medicaid. But they're still with Kaiser because we offer plans in both markets, and then they're no longer able to get their behavioral health services through us. So we'd like to explore the idea of a pilot program where we would be able to provide those services to Medicaid patients in-house. We'd be happy to present about this at the Behavioral Health System of Care Work Group or discuss with any stakeholders who may have questions about what we're trying to do. We're just trying to address what we see as an issue that's unique to our system. So that's the first thing I want to speak to the committee about. The second does relate to the value-based purchasing program. We have invested a lot of money in the past several years since we joined the program in 2014 to improve our quality and to provide really high quality services in the Health Choice program. And I think that we're doing a good job at that. We are concerned with some of the changes that are being proposed by Medicaid, including the elimination of the disincentives. One feature of this that hasn't really been discussed is it would, if it's not built into the rates, which we think would be a good solution here, then it does require additional funding from the states. That hasn't always been consistent. In fact, I don't believe that the state has committed to funding it for 2021. It's hard for us, not only Kaiser, but any MCO to plan to be able to meet the targets if it's kind of unclear what's going to be available from year to year. I would propose, probably at least 2 years out of knowing what we need to meet so that we can plan to meet those targets would be helpful. So we are, happy to continue working with the health department. They're great partners, and we appreciate that. So on each of these issues, we'd be interested in some committee narrative. First, on the behavioral health issue, requesting that the department work on a plan for an MCO to have a pilot program like what I've described. Second being for the department to explain in a report what changes they're looking for related to the value-based purchasing program before moving forward with any changes in regulation or policy. Thanks for the opportunity to testify today.
Thank you. Mr. Sunarine.
Good afternoon. My name is Jai Sundarine. I'm the Chief Executive Officer for Jai Medical Systems. I appreciate being with you all, albeit virtually. For 23 years, our company has served in the Health Choice Medicaid program, and we are recognized as the highest rated MCO in Maryland. And it is not an easy feat to be the highest rated managed care organization in Maryland, notwithstanding being the highest rated in the country. And the speaker before me was from Kaiser, and they are also one of the highest rated in the country. That sort of quality is not really something that happens by accident. It requires an investment. It requires outreach. It requires people going to people's homes to make sure that they're okay, and to bring women in for mammograms, to make sure children receive immunizations and lead screenings, to make sure that chronic care conditions are managed. At its core, the VBPI program is intended to ensure that the people served by the Medicaid program receive appropriate health care. Unfortunately for CY 2021, that's where we are right now. This year, the VBPI program has been effectively canceled. We are requesting the committee's assistance and the department's assistance in looking at this, because we do believe that the program should function appropriately with a system of disincentives, incentives, and neutrals. I know that the department's response has singled my organization out and shown our growth, as well as the growth in the second round of payments to our organization. But I think it's important for the committee to realize that the growth in that second round is a function of other MCOs performing poorly. That is the disincentives that the department has collected. And unfortunately, over the last, I'd say 3 or 4 years, MCOs have seen a decline in their performance, which has led to an increase in the second round of payments. Unfortunately, some of the recommendations that this committee had last year were not allowed to go into place for this year, but they certainly would have addressed some of the concerns that we're seeing right now in terms of the growth of the second round. The second concern we have has to do with the department's plan to change the essential nature of the program, eliminating the disincentives, and making the second round very small. I think that's a problem. I don't know that there's any evidence that by making poor performance less consequential, we will somehow improve MCO performance. So as the highest rated MCO in Maryland, we believe the existing VBPI program should be strengthened and preserved. Some of the ways the program could be strengthened include ensuring the recommendations adopted by this committee from last year are given a chance to work. Ultimately, I personally believe the VBPI program, when working as intended, has benefited Maryland. After all, to the department's credit, and thanks in no small part to the VBPI program, Maryland is home to the 2 highest rated MCOs in the country. This is a distinction no other state can claim. I want to thank the committee for its time and would be very happy to answer any questions you may have.
Thank you. Let's move on to, let's do one more person because I made a mistake about the number of panels. I had included written testimony in the oral. So there's only 3 favorables, 2 unfavorables. We'll take the third favorable, and then we'll move on to the ask questions, and then we'll move on to the unfavorable. So I'd like to call Mary Backley of the Maryland Dental Action Coalition.
Good afternoon, Mr. Chair and distinguished members of the committee. My name is Mary Backley, and I'm the Chief Executive Officer of the Maryland Dental Action Coalition, a statewide network of individuals and organizations working together to improve the oral and overall health of Marylanders. Although Maryland Medicaid currently provides dental coverage to pregnant women, the coverage does not extend to postpartum period. The Maryland Dental Action Coalition is thankful for the advocacy of Senator Guy Gazzoni and Delegate Mike McKay in championing postpartum dental coverage, and Governor Hogan's support to close the gap between dental and health coverage. The budget brought before you includes funding for postpartum coverage for dental care. There is a strong link between oral health of a mother and her child. Studies show the women who access dental care during pregnancy and into postpartum period have children with fewer dental caries. Tooth decay is the most common chronic childhood disease, and it is preventable. Postpartum dental coverage would give new moms the opportunity to establish a dental home for themselves as well as their child. It would also give providers the opportunity to talk with women about the importance of oral health care to their overall health and to teach them how to give their child a healthy mouth for life. On behalf of the coalition, I want to thank you for the opportunity to be here today and for your leadership and commitment to expanding access to dental care for Maryland's most vulnerable population. Thank you.
Thank you. Any questions for one of the three or any of the three people who just testified? Not seeing any. I want to thank you all very much for coming to testify. We're now going to call the unfavorable panel. Tanya Kinlow of Children's National Hospital and Laura Bogley of Maryland Right to Life. Ms. Kinlow?
Good afternoon, Chairman Resnick and members of the Budget Committee. Thank you for having me today. I'm Tanya Vidal-Kinlow, and I'm Vice President of Community Engagement Advocacy and Government Affairs at Children's National Hospital. Here to talk to you about the Medicaid program, but want to share just a little bit about Children's National before I do that. We are, of course, the primary and specialty health care provider of services to thousands of Maryland children. In addition, Maryland children rely on Children's National for emergency medicine and trauma services. We are the only level 1 trauma center in the Washington metro area for children, for pediatrics. I will tell you that our commitment to Maryland is strong. Last year, we increased access to our broad range of services for our world-class pediatric specialty care, medical and surgical care by opening our new Children's National Prince George's County Regional Outpatient Center. Of course, that is one of our newest locations. We have locations all across the state of Maryland. I would say that your children rely on us for their pediatric care. The facility in Prince George's is a 60,000 square foot comprehensive pediatric care center and is the largest outpatient center that we've built to date. Now about Maryland Medicaid. Maryland Medicaid is our largest source of funding. As shown on page 19 of the DLS budget analysis in Exhibit 9, Children's and other DC hospitals received a payment cut in July 2020. And this was the action taken by the Board of Public Works that you've heard about earlier. Also, as shown in Exhibit 9, DC hospitals were the only providers of healthcare services to receive a rate cut. At the time, we acknowledged that things looked bleak. We were all struggling under this COVID-19 pandemic. And we recognized that there might need to be some changes. And Children's National itself was impacted, obviously, by the COVID pandemic and experienced some tremendous fiscal challenges. So when you look at page 28 in the exhibit 16, the hospital saw material drops in patient volumes, both inpatient and outpatient, and Children's experienced the same declines in patient volumes. And I think you understand that the cost of providing care during that time increased because of all that we had to do to protect both our patients and our staff from the COVID-19 pandemic. And so all the additional costs related to that. So we're losing patients and we are increasing the cost of providing care, and we're experiencing this rate cut imposed on us by the state. So those two things combined really places a significant burden on our hospital and on our ability to continue to provide the excellent quality of care that we know our community has come to rely on from us. And so I would say to you that this rate cut was the wrong thing at the wrong time. I'd also like to point out that in 2020, the General Assembly agreed to raise the Medicaid rate to DC hospitals, and it was enacted in the BRFA in the form of the 6% provider tax. And while the DC hospitals received the cut at the Board of Public Works, the Maryland hospitals received a 4% rate increase. And since then, other healthcare providers have also received a 4% rate increase. And the only hospitals experiencing cuts at this time are hospitals like Children's National. And this rate cut is permanent, as you heard from the department's representatives. It's not temporary. And so what we are respectfully asking you to do is to reinstate the Medicaid payment rate cut imposed on DC hospitals. And we also would like you to get a commitment from the state that the cut will not continue into fiscal year 2022, and that the reduction to the payment base rate is restored for the purposes of calculating the DC hospital payment rates moving forward. So I know that's a lot to ask, but it's all very important, and I'm hoping we can count on your continued support. That concludes my remarks.
Thank you. Now, Ms. Bogley.
Good afternoon, chairs and member of the Joint Committee. I'm Laura Bogley, and I serve as Legislative Director for Maryland Right to Life. On behalf of our members across the state, we strongly oppose any budget allocations or increase in taxpayer funding for abortions or abortion providers. There's no constitutional right to abortion funding. By forcing taxpayers to fund abortion, the state is infringing on our natural and constitutional rights to life, liberty, freedom of speech, and religion. The administration includes at least 3 programs that fund abortion providers: the Medical Assistance Program, the Children's Health Program, and the Family Planning Program. The Medical Assistance Program is the primary vehicle for Medicaid reimbursements to abortion providers. The BRFA seeks to transfer another $100 million in fees each year for provider reimbursements under the administration. But if the goal of the state is to make abortion safe, legal, and rare, the state is failing. The more we spend on abortion providers, the more abortions are committed. In 2016, we paid $5.4 million in Medicaid for 7,899 elective abortions. In 2019, we paid more than $6 million for more than 9,660 abortions, none of which were to save the life of the mother. That is more than an 18% increase in just the last 4 years on elective abortions paid by taxpayers. But this is just one small piece of the abortion puzzle in Maryland. The state is involved in risky business, referring pregnant women and girls to Planned Parenthood and affiliates for family planning and prenatal care under the administration. Planned Parenthood profits from abortion. In fact, they sold 354,871 abortions just last year, nearly an all-time high. But their prenatal services are down 73%. Planned Parenthood reports that they commit 41 abortions for every one prenatal care service and 133 abortions for each adoption referral. As long as the state entrusts those who stand to profit from the sale of abortions with the education and care of women and children, abortion will neither be safe nor rare. Pregnancy is not a disease, and therefore abortion is not health care. Abortion is an epidemic, and it is the leading killer of Black lives, more than gun violence and all other causes of death combined. 80% of people agree that women have better options for prenatal care, and public funds should be prioritized for programs that save the lives of both mothers and children. This is scientifically possible. For these reasons, we respectfully urge you to uphold your oath of office to protect the constitutional rights of all human beings, born and preborn, and vote against any budget allocations for abortion providers. Thank you for your time and the opportunity to discuss today.
Thank you. Any questions? Delegate Mangione.
Thank you, Mr. Chair, and thank you, Laura. I just had a quick question. For those 3 programs that you mentioned where the funding comes in from the programs, do you have the amount, or do you have any idea how much the state is paying to fund those abortions? If not, I'll have to talk offline with our departments and try to get those numbers.
Right. Thank you, Delegate Mangione. The only information that we have published as part of the budget each year is the medical assistance payments for abortion providers, the direct Medicaid reimbursements. We don't have published every year as part of the budget from the state the MCHIP numbers or spending, or any information about to which prenatal care providers or family planning providers the state is referring pregnant women and girls under the family planning program. So that's an area where we need to improve the transparency, and we would ask the state to include the breakdown of the spending under all of the programs under the administration. And I would just refer you, Delegate Mangione, probably to the state and to the state analyst for the budget to explain where that information is. If there's a line item, that provides that amount, it's certainly not something that's readily available to the public.
And thank you. Yeah, I'd like to know myself. So thank you. I'll reach offline and see if I can get some more information.
Thank you.
Thank you. Any additional questions? Seeing none, I want to thank you all for testifying today. Really appreciate it. Tomorrow we conclude budget hearings with the final 2 budgets, I believe, the Developmental Disabilities Administration and the Department of Aging. Look forward to next week. We'll have formal decisions and move along the budget process. So thank you all very much, and we will see you tomorrow. Meeting adjourned.
Thank you.
Thank you.
Bye, Tanya.